four distinguished guests. Adam Vojtěch, Minister of Health, Czech government. Then we have Erik Henriksen, CEO of Healthcare Denmark. Third speaker will be Miklós, Szócska, Director of Health Services Manager Training Center from Hungary. And the fourth presenter will be Petřík, Director of Institut for Support of Czech eHealth. So each speaker will have 20 minutes space for presentation, and at the end we'll have a panel discussion, and I like to motivate the auditorium for the fruitful discussion at the end. It will be, I think, the key outcome of this session. So may I ask you, Mr. Adam Vojtěch, to start your presentation?
I'm not sure that I'll consume all the 20 minutes, but because maybe I prefer this discussion, but I'll try just basically to show you how or what we think that eHealth should be established like digital healthcare. We want to the architecture of eHealth to be connected to the e-government services, which is very important. In the Czech Republic, we have national basic registers, which are working. It's the register of persons, register of rights, and so on. So we need to connect this new e-health system to these registers because and we want to make the architecture like in-house. That's our main aim. That we don't want the e-health to be built by external companies, because in the past we didn't have good experience with it. So I think it's important that we have this in-house architecture. But of course, we need to use the external experts because either in the Ministry of Health or health insurance companies, they are of course not the experts for these IT technologies. Of course, right now, one of the main topics which is being discussed is GDPR, data protection, which is also connected to eHealth eHealth system. So we need to guarantee strict protection of sensitive personal data, but also we need to share the data. So that's what it's all about. That the data should be protected, but we need to share them. But it's important that the sharing of the data will be secure because of the data sensitivity and personal data sensitivity which are being shared among healthcare providers. So we need to guarantee that all these points will be enforced. So data protection and secure data sharing. And we need to connect all these data, the eHealth registers, to the national basic registers and to the e-government services. As I mentioned already, in the Czech Republic we start with electronic prescription, which is, to be honest, not very systematic, but that was a decision in the past few years that the electronic prescription will be maybe the first really like e-health project. So it's now enforced, the law, since the beginning of 2018. So it's obligatory, the electronic prescription. All the healthcare providers are obliged to prescribe electronically. There are some some exemptions, but basically right now we see that 70 to 80% of prescription is made electronically. So from my point of view, it's maybe more successful than some doctors or representatives of healthcare professionals said in the past year. They said that the healthcare system will collapse. It did not. It works, and it works quite well. The thing we need to improve is the database of the list of prescribed drugs which should be shared among the healthcare providers. That's one of our main aims for this year. We need to again make a new law. We are now working on it, but it's very important because of this list of prescribed drugs which will be shared among providers. We can guarantee that there will be no bad interactions between the drugs. There will be no duplicity, because it's a problem right now that the doctors don't know which drugs have been prescribed to one particular patient, so they can't see this list, and that's what we want to change. So there will be all drugs prescribed to one particular patient, and this list will be seen by all the doctors, all healthcare providers. Of course, we want the patient to have the right to opt out, because it's obvious that we can't force the patients to accept that all their data will be shared among the providers. So we need to give the patient right to opt out, which is from a point of view natural, and we want to connect this system. It's also one of our aims for this year, to the register of healthcare professionals. So because right now we don't have this register, it will be in force since March. So it's maybe a little bit absurd, but right now there is no 100% register where you can identify that a doctor is really a doctor, which is maybe ridiculous, but it's like that. So that's one of the registers we want to make into function, and then we want to start it since March. And this register will be connected to the electronic prescription. So all the when the doctor will try to or will prescribe some drug, it will be controlled that it's really a doctor that can prescribe the drugs, and it's really a doctor that has this competence. In the future, of course, we talk about the e-identity. Right now we have a kind of problem with this, and it's being criticized also by the doctors. That it is very complicated to get electronic signature. The whole process is pretty complicated. It takes weeks. In the future, I hope, and it will be, quite near future, there will be this e-ID card for all the citizens, Czech citizens, and we will use this e-ID for identification either the patient or the doctor. So that's what is not connected directly to the Ministry of Health, but to the Ministry of Interior Affairs. But I hope it will work like that. There is already new law in our system, legislative system. So we have to hope. From my point of view, as I see it right now, on that example of electronic prescription, one of the main problems is communication between the doctors, the lawyers, or the people who make the legislation, also the Ministry of Health, and the IT experts. What we want to do, and we really focus on it when we now build some working groups and so on, that we really want to have all these stakeholders involved in discussions about architecture of eHealth, which is very, very important. That the doctors, because of course the doctors are not professional in IT, so they still are a bit afraid. That's one of the examples, the electronic prescription, how it works, whether it's secure or not. So it's very important that all these stakeholders are included. We work on it, and yeah, that's it. Like healthcare professionals, legislators or lawyers and IT experts all together. Yes, so thank you very much.
Thank you very much for the excellent presentation, and the next one will be dedicated to the situation in Denmark. Denmark is one of the leading countries worldwide in the field of eHealth, and we'll see how is the actual situation and how was the history in Denmark, please.
Thank you very much. Thank you very much for the invitation to talk about what's going on in Denmark. I'm Henriksen and I'm CEO of Healthcare Denmark. Healthcare Denmark is a public-private partnership which on the public side is owned by the Ministry of Health, the Foreign Ministry of Denmark and the Ministry of Business and other public stakeholders. On the private side we are owned by Confederation of Danish Industry and Confederation of Danish Enterprises. And our mission and role is to have kind of the dialogue with other countries about how we can improve our healthcare systems and counter some of the challenges all healthcare systems, at least according to our experience, are facing. We are proud to have our Royal Highness, Crown Princess Mary of Denmark, as a patron for Healthcare Denmark. She definitely wants to lend her name to this mission of more dialogue between the countries. And how we carry out this mission is actually quite simple. We have a dedication visitor program, so if any of you think after the presentation this is interesting, we want to go see what's going on in Denmark, then you can actually make a request to me or to our webpage to pay a visit, and we'll build a delegation visitor program for you. Last year we had 5 ministers of health from other countries visited us. We speak at international conferences. We join our ministers and royal family when there are official visits to other countries and healthcare is on the agenda. We use communication and press to spread the message about Danish strongholds. And if you go to our webpage, you can find videos and information about where we as Danes think we can contribute with inspiration to other countries. So in my presentation I'll give you an introduction to Danish healthcare so you understand the setting. I'll talk a little bit about the strategic challenges we have in the Danish healthcare system, and then I'll focus on where we are on eHealth, how we got there, and I'll talk specifically a little bit about also e-prescription. The Danish healthcare system is a single-payer, universal coverage healthcare system, which means that when we have paid our taxes, healthcare is free for all Danes. The size of the taxes, that's another story, but the main point is you can go to a general practitioner, specialists, clinics, hospitals, it's all paid by the taxes. And that makes the Danish healthcare system quite simple. We have the Ministry of Health and the board and directorates. We have 5 healthcare regions. They own and operate all the hospitals in Denmark. They're also responsible for managing our general practitioners. general practitioners in Denmark, they are private enterprise because they get 98% of their income from the regions and the public system. And we have 98 municipalities who are responsible for elderly care, home nursing, population health and prevention, and also rehabilitation. So in Denmark, when you need help from the healthcare system, you start with the general practitioner. And only if the general practitioner agree, yes, you do need to go see a specialist or a hospital, only then do you move on in the healthcare system. That helps make our healthcare system very efficient. Actually, 9 out of 10 encounters, they're handled at the level of the general practitioner. So that was the Danish healthcare system, universal coverage, single payer, paid by our taxes. Probably know these challenges. The fact that our population is growing older, we get a larger share of the population over the age of 65, but they live longer, they get more chronic diseases, they need more help from the elderly care facilities. Chronic disease challenge, you also know, the fast food generation, the fact that we are not moving so much at work is contributing to that. And different and more expectation than more informed patients and citizens is another challenge. So those are challenges putting healthcare under pressure, increasing demand for healthcare. At the same time, we have more research, more innovation, more new treatments, more new medicine, more expensive medicine coming to the market that is putting healthcare under budget pressure. So this is kind of a perfect storm, more demand for healthcare services and more expensive. In Denmark, in the early 2000s, demand on the healthcare system was so severe that the government had to open the lid and allow patients to go to private hospitals if the waiting list was too long. And that started a process, kind of a notion going in Denmark saying, if we want to keep a tax-financed healthcare system, we need to transform the healthcare system. We cannot just react by building new hospitals when demand go up. We need to deliver healthcare in different ways. And this is why today in the Danish healthcare system there's a huge focus on a lot of political initiatives on early detection of serious diseases, cancer, chronic diseases, because that's an opportunity to address those developments before it develops into something that requires hospital treatment, operation and expensive chemotherapy. There's a focus on population health and prevention initiatives, increasing the health level of the Danish population, motivate smoking cessation, reduce alcohol consumption and more exercise. There's a focus on delivering more healthcare in the primary healthcare sector, and that's definitely a focus on using eHealth and telehealth to involve, educate and empower our patients. What we have learned in Denmark is that you all think it's nice to have access to your own electronic health record. But the point is that eHealth is strategic when you reach the level of Denmark, because when you reach that level and you have the data to share, it's opening up for new initiatives like telehealth and personalized medicine, where you need that kind of data to make it work. So eHealth is really strategic. Assisted living, keeping our elderly citizens healthy, self-sustained in their own home as long as possible is an important focus. And personalized medicine, where we have the first public sector strategy, a public healthcare system that say we believe personalized medicine and precision medicine is a strategic advantage and we need to have a strategy on that. So this notion coming around 10 years ago has already led to some improvements. Productivity on Danish hospitals has gone up by 30% since 2003 due to initiatives which were established 10 years ago, meaning that today we treat 30% more patients with the same budget and the same staff. Even though that is the case, patient satisfaction has gone up and it's stable, and we do have our economic spending on healthcare under control. It's going up, but that's because we have some huge investments at the moment. And a focus on quality in hospitals has made the hospital standardized mortality rate go down. And this is driven by different initiatives and strategies. This is healthcare IT strategy number 5 since 1999. And this is the very new healthcare IT strategy, Digital Health for Denmark, that came out only a month ago. This strategy is the most extensive, comprehensive strategy for digital health ever in Denmark. It's continuing to build on what we already have in eHealth, which I'll present in a moment, and at the same time, it is providing support for those strategic initiatives, early detection of serious diseases, telehealth, patient-reported outcomes, building a strategic digital relation with the citizen and the patient, so you can motivate them before a treatment, you can save on outpatient visit during the treatment, and you can follow up on rehabilitation and their experience of quality after treatment. Supporting integrated care, accelerating the creation of coherent healthcare system where we have the opportunity to place healthcare services where we have the lowest efficient cost. It's much more efficient if you can use IT connections to allow a home nursing nurse to do some action which previously required hospitalization, or GP for that matter. Population health and prevention, and a whole strategy in that area is part of this picture too. And when we do this, and when we embark on a mission to implement personalized medicine, precision medicine, we need to work more on data security. But it's not only about making data secure, it's also building on the trust that Danish citizens have for lending their data to the public healthcare system. We must not lose that trust. That's part of the strategy. And then expanding the national health IT architecture to support personalized medicine, patient-reported outcomes, and a move from web-based eHealth to app-based eHealth is also part of this strategy. 27 initiatives over those 5 main areas is the strategy. And this is aligned with the digital welfare strategy, assisted living strategy, where the aim is to use technology to keep our elderly citizens healthy in their own home, combine that with home nursing staff to have that relation and spot deteriorations among elderly citizens as early as possible. And with these initiatives, we push healthcare closer to the citizens. That is changing the role of the hospitals. And that is the reason why in Denmark we have reduced the number of hospitals from 98 and 99 to 32 as I speak, and we expect to get down to 25 when we have completed the 16 new super hospitals, which will be the backbone of this new hospital structure. It's an investment program of 5.5 billion euro. It's ongoing right now. You can see some of the new hospitals, and the rest will be completed towards 2025. 8 of them greenfield, 8 of them refurbishing existing hospitals. So this is really a map of hospitals for the future, because at the same time, those 32 other hospitals that remain, they have changed their role and the specialization, because we need higher specialized hospitals in the future. I mentioned personalized medicine and the size of the equation where we use genetics. There's nothing mysterious about that. It's a question about building it. Some other countries have done it. The reason why this makes sense for Denmark is the phenotype side of the equation, because to make personalized medicine effective, you need to know the other healthcare data of the citizens. In Denmark, we have electronic data going 40 years back in time related to hospital activity. We have data on the level of electronic health records and clinical databases going 20 years back in time. And we have a national biobank and a network of biobanks with 25 million tissue samples, all connected by one unique patient identifier. So you can track a person through all these data, and that is truly unique, and that is the reason why it makes sense for Denmark to embark on such a strategy. So, eHealth, to start with the beginning, in 1994, one of the leaders in the regions, he did a study. And he found that nurses and doctors, they were spending around 30% of the time handling paper. Finding the lab result, the response from the radiology or the referral letter and or the prescription, not to talk about the paper record. So we went to the Ministry of Health and he said, hey, it's 1994, we have the PC. What if we could exchange all this data electronically? Then we could potentially save all the time that is spent handling paper. And the Ministry of Health said this is a great idea, and that was the start of Medcom, an organization with one mission to build an electronic health data network. Around 2002, they were successful. Around 60 to 70% of all lab results, prescriptions, reimbursements, referral letters, discharge letters were flowing electronically. So somebody got the idea to say, hey, if we have all this electronic data now, Medcom has also driven up the adoption of electronic health record and IT systems everywhere in healthcare. Why don't we use it to share with our patients and clinicians? And that was the start of the National eHealth portal, which went live in 2003. So today, as a patient, I have access to my full electronic health record. And I can see information about symptoms in the eHealth portal, information about every healthcare institution and hospital I can go to. But it's also a tool for the clinical professionals to help them keep their knowledge up to date on new research and new methods, and they have the same access to the electronic health records. So the data I have access to is my DP's name and address, it's my latest medicine, and I can dwell in and work in detail with medicine. I can renew a prescription electronic, and at the same time I can order the medicine from the pharmacy. I can also dwell into these 40 years back information about hospital activity. I can go into details of clinical notes from my DPs and details on clinical notes from our hospitals. I can see all my lab results, and I can also dwell into data from different specialists. So essentially, it's a complete electronic record which the patients can access themselves. And all clinical professionals who have me in treatment, they have the same access. So we share the data across the healthcare system. Hospitals, they have their own system which cover all hospital activity, outpatient activity, and they report the data to the National eHealth portal and this shared electronic health record, actually through the Danish health IT architecture, similar architecture which we just heard you plan to build here in Czech Republic. Data through this architecture is ending up in the National Service Platform, where you have the information of all the doctors who are authorized. You have the unique patient identifier, you have medicine information, you have security services. And security services are, by the way, the same public key infrastructure we use to guard our bank information and also for our e-government contact with public authorities. So the way it looks is that you have this healthcare architecture, and you have the National Service Platform which manages different repositories. So it's not one system, it's different systems that are tied together by the National Health Architecture. And this is important because when we started to do telehealth projects, suddenly we find out now we have devices in the patient's own home. Where do we put these kind of data? There we saw the stronghold of this architecture because we just added another repository under the National Service Platform, and immediately we could start sharing this data. We could start doing large-scale telehealth projects. So as you can see, all the 5 regions, they have their own copy and instance of the data. So if communication fails, they are still in business and data is replicated back and forth. So if a GP or a hospital doctor, they look at their medicine list in their own system, they see all medicine the patient is getting, not only the medicine they work with, because data is replicated both to the National Service Platform and the other way. You can see it's uniting the whole healthcare system, municipalities, regions, the health portal, and also our telehealth projects and the 3,600 DPs we have in Denmark. And where we go next is from web-based eHealth to apps. The National eHealth portal is available as an app, and so is now the e-prescription. And the e-prescription had an uptake in a record time of around 1 million Danes using it. And the reason is that it's so much easier, as we heard this morning, to use an app. If I want to renew my prescription, it's an existing prescription, I just take my app, I swipe it, and then it's renewed. So that is where we are going also, new digitalization strategy. And finally, what I have talked about is closely linked to the e-government strategy of Denmark. Currently we have the problem that the postal service of Denmark is going bankrupt because nobody is sending letters. All citizens use their electronic mailbox for communication with public authorities. companies use the same electronic mailbox. And that is due to the e-government strategy, which is linked to the eHealth strategy and guarded by the same PGI. So if you want to know more about that, the Danish embassy here in Prague will be very happy to give you more information, also spreading for the e-government areas to what I'm talking about. Thank you very much for your attention.
Thank you very much. Excellent presentation. So I wish we will have here sometime in general such a really working system you developed for, let's say, last 15 years. Congratulations. It's really amazing work. Good. We have to move to the third presentation, and I'm happy to hear how was the development in Hungary and what is the existing status and the future of eHealth in Hungary.
Thank you very much, and I have to tell you that whenever we wanted to move forward for development, many times we went for inspiration for Scandinavia and also to Estonia, and also I have to admit that we called Denmark the socialist kingdom of Denmark, because they are so civilized and they can debate professional issues without killing each other, and they can achieve such a nice progress. And you know, many times we allied our forces because they have a retrospective 20 years of data, and the data protection regulation kills that. You cannot use that data for multi-morbidity development. So it was really a Hungarian, Nordic, Estonian alliance when there were some EU debates, and we all understood what we were talking about. And then I listened to the presentation of the Czech reforms. Yes, we have this electronic ID card already, and you know, one of the reasons that the Hungarian doctors were willing to use it so fast is that from '93 we have DRGs, we have unique patient ID cards, we have German points in outpatient service, and we have per capita financing in primary care, but all the doctors are used to report electronically to the health insurance fund. So putting another layer from November the 1st, 2017, there was not a turmoil, this was just one new point in the menu, in one new menu item on the menu list of their computer systems. Of course, they do not necessarily as disciplined in putting in the data as the Danish or the German colleagues would be, but there is the culture of using computers and using electronic records and reporting in the Hungarian system. And you know, what I wanted to say that I do not necessarily will talk about the system. I will give the references what we do have. Today in Hungary we have a joint national integrated data platform. So the doctor, my wife is a GP, and she said around Christmas, she said, who is the person who at an office desk decides that I have to join this computer system? And she never admits when she was rude, but in January she said, now I start to enjoy this data space, because if I refer a patient to a hospital, I can see what happens with that patient. So the power of the eHealth system comes with the application. So the data integration is not for the provider. It's not because we have telecommunication lines, but because we can save lives with that. Now this is administrative data. We took over the ownership of all the hospitals from the municipalities, and we data mined the unpaid invoices. And what we saw, that it is some hospitals who accumulated most of the debts, and we understood that it is the exact same 14 or 16 companies who were providing goods and services for all the hospitals in the hands of 100 different municipalities. So there was a monopoly market formation. So simply from financial data emerging from the electronic administrative systems in-house showed us the business model of hospital procurement. So we introduced joint national procurement on pharmaceuticals. We saved 38%, gas 20%, electricity 15%. This means saving money, sustainability, saving lives, giving more health from the same amount. Okay, this is the, we procured gas on 104 forints, and this is the prices before this guy was arrested, because all his prices were procurement prices. So it was not me who made him arrested. But again, this is e-prescription. We have e-prescription system since November the 1st. 96% of the prescriptions is in the e-system. We do not have the application yet, but we are working on it to have it on a national app. But you know, one of the pharma companies started to blackmail us that they do not pay the extra tax and they pull out from the subsidized pharma market. So there will be 3 weeks before Christmas. The company was Danish. Sorry. And there will be 3 weeks before Christmas, and we had to change the medication of 50,000 patients. So we were looking in the publication data, who are the key opinion leaders. And what we saw is that it is very much centralized, but we became suspicious. Hey, that many people publishing with that company, and it is so centralized, there has to be an incentive, So we looked on the prescription habits. This is the company that blackmailed us, this was another one and another one. And you see those who prescribed the pharmaceuticals alone are 3 times more than the other 2 competitors. And they had a 25% price advantage. And those who prescribed in combination with the other 2 were 3 times as much or 4 times as much as the ones who prescribed the other two procurers medication in combination. So we understood that as the 25% price advantage goal. We showed it at a medical association meeting, and 3 days later we got a phone call from the pharma company that they they masked the price from the international price comparison, and they paid the tax at the end. So it was even good for political gaming. But this data, the electronic prescription data, can be used for compliance or therapeutic adherence. And in the case of diabetes therapy, for a doctor to see whether the patient adheres to the therapy is the prevention of complications. So the e-prescription is an administrative exchange system, but you can use it for saving lives. And of course, public money later. This is tobacco trade data, lung cancer data. The red dots are areas where people, where low-income population lives, and they buy fine-cut tobacco. So these charts from various trade data, health data, and income data, if you combine this data, you understand that the poor smokes the worst tobacco and dies earlier. So the power of health data combined with other social data is even more powerful. So when you establish an eHealth system where there is data exchange and where you can use the data for secondary purposes, you can really do a lot of stuff. And this is the next generation. So in Hungary now we have an integrated data platform, some applications like e-prescription, and the doctors can see the data, and the patient can see the data through the government portal. But this is the next generation. So we are in the process of researching and developing applications. This is 2 types of diabetes and all the complications. The darker the dot is, the more people involved or living with that complication, and the broader the edge between the dots is, the higher the costs. So here you can compare the chronic care management of 2 GPs, or the outcome of the outcome that the system provides to the patient. So, and if you build this intelligence on the level of giving feedback to the doctors, or the regional director, or the patient pathway manager, you can really do a lot. So now we are working on a research level, we are working on a telemedicine system, and we are working on artificial intelligence solutions, and we are also working on the next generation eHealth, which will be a cloud-based joint national eHealth system with joint national databases. And yes, it has to be in the hands of the state. And because it is your body tissue, it is publicly financed health service, and it is a publicly paid doctor most of the time, and data should be a public asset and should not be used for clandestine private purposes. And that's a huge issue, whether you trust the data. How am I doing with time?
You are okay, so you can continue.
Good.
It's
okay.
very interesting.
Yeah, thank you. Yeah, there is this there's a national application, and you can put your blood sugar here and you can collect data. It is not broadly used yet, but the integration with the national platform is underway, and what Hans-Erik showed you, it will be a reality in 1 or 2 years in Hungary. Developers are working on it. A huge issue is that we have the methodology center is a little bit weak. So one of the strategic challenges is whether we can have what is your company or data center called. So if we have national service platform, if there is a good methodology people there, and that's doctors and IT people too, because doctors should know the multimorbidity issues and doctors should think about the applications. And there we are weak. And there's a lot of work and political balancing, but so that's a huge issue that you have a methodology center and civilized debate and civilized development. Now, social media. You all hear these news of anti-vaccination activism and the strengths of it. In Hungary, we introduced HPV vaccination back in 2013 and 14, and we wanted to see whether there is a social media activism against it. So we downloaded the Facebook communication of the anti-HPV vaccination activists. Basically, there was one very active guy, basically it was 2 guys and 4 bridge persons, and this is a very, how to say, limited community. So no external messages spread. So we understood that, okay, there is no need for a positive communication campaign. The vaccination is a stable issue in Hungary, so we do not have to do anything. But when you think about, this is the same methodology that you can use preventing depression or other cases. And imagine when you can link this data with the clinical platform data. So there's a huge platform to find out new methodologies, how you reach, for example, depression patients or suicide patients. The same logic the NSC and other agencies are trying to trace radicalization. That's the same stuff you identify depression or suicidal thoughts or whatever. And just 3 more. You see organizational culture in data. This is a publication data set again. This is a traditional university professor. He demands everybody to put his name on the publication. It sits on a pyramid. So you even see organizational culture this is just fun. Brexit. We downloaded the Brexit data, and you think that the Brexit did not have anything to do with health except the NHS. But when you look on that, menthol cigarettes, tobacco and e-cigarette was among the most frequently mentioned topics among Brexit activists. You start to think, who financed Brexit? So when the health policy people are trying to solve some political issue or trying to develop health policy or convince others, you can use data methodologies way beyond the health records. And in Hungary, we try to combine these kind of tools with the traditional tools of eHealth. And the last is a joke. There's even the joke in the database. There's the old joke of the neurologist. Whether a patient with incontinence goes to every doctor and ends up in the hands of a neurologist. He could not help him either, so at the end he prescribes a relaxant. So the guy disappears. 3 weeks later they meet on a bus, and then the doctor asks, hey, are your problems are solved? Yes, yes. So you do not pee anymore. I still do, but who cares? And again another Danish company, Ferring, asked us to do this analysis. This is patient communication of irritable bowel disease patients, chronic condition, and we showed it, when we showed it to the young gastroenterologists, and they saw that the joke is in the system because the most frequently conventional medications by the patients is the gastro drug and the relaxant, the foaming Xanax. So the joke is in the system. And you know what was the first question from the young gastroenterologist? Do we really help our patients? What can we do to help our patients better? So the clinical data, administrative data, and social media data, whatever data you can access, can also fuel clinical practice development, which is basically the patient, the beneficiary is the patient. Sorry, that's the story for which we use the Hungarian eHealth system.
Thank you very much. Again, excellent presentation. So I'm really positively surprised how Hungary is very far in the big data management. Congratulations. Next presentation will be given by Mr. Petřík. He will probably show us the potential role of a private sphere in the development of eHealth.
Thank you for the introduction. I'm here as the director of the Institute for Support of eHealth. However, how irrespective how robust it sounds, it's a private company and it's a private initiative, I would say. So on the sides of eHealth implementation as presented by Mr. Henriksen, we are on the side of private partners, I would say. Yeah, so though we would like to take a strong role in Czech eHealth, we are really partners from the private sphere. Maybe I will not have the opportunity to thank my co-speakers, but I must say that all the presentations were very impressive, I have to say. The Hungary experience with data use, data mining, it's huge, I would say. It's excellent. The long way which was done in Denmark and the partnership among the e-government and private sector, the use of all these applications, etc., it's also for us a big help for us for our processes and thinking and evaluation of the possibilities. And I must say that I have to thank also to Mr. Vojtěch as the Minister of Health, because I think he's the first Minister of Health who comes with some strategic solution in eHealth. So we really invite any strategic integration, and we really invite any systematic work on the case. So thank you very much. In the beginning, I said we are the Institute for Support of eHealth. The Czech experience with eHealth gives these two words, support of eHealth, in an absurd connection, I must say. Because each time there was any support of eHealth in the Czech Republic, the physicians, the hospitals, the practitioners, every time shoot back, And the biggest experience here, even from the last cases, is that eHealth is something very varied for physicians. But we have chosen this way, and we would like to support eHealth and support eHealth projects and support eHealth projects done by the state as well as the projects done by the private part of the side of the world, of the eHealth world. In the beginning, we were thinking about where to start with, and this is the basic electronic health record, the basic record, the basic data, which we have chosen for our initiative and for our platform, I would say. Last year, I've shown you here another definition of electronic health record. For this year, I've chosen the definition from World Health Organization eHealth report, from innovation to implementation. It's very long. However, for us, the implementation of this was rather simple because we've set, let's say, questions. Why the support of eHealth is so absurd here in the Czech Republic? And usually it's because of the fact that the physicians feel that eHealth brings just new administration, new bureaucratic obligations, and generally speaking it's a new legislation and difficulties for their work. Even now they say that they spend 60% of their time by doing papers, and they don't have any other space for putting anything into computers, I would say, simply speaking. On the other hand, they ask for information. They ask for connection. There are good examples from private sphere that some systems could work and could help either patients as well as to physicians to fulfill this, in fact, to put information into some kind of patient-centered system. So to give patients a certain bag, virtual bag, where all records will be systematically downloaded, and all the records will be sort of ownership of the patient, the electronic health record of the patient. The health record will contain the patient medical history, and we come to the third point. Usually when we enter a physician's office or hospital, the first comment is we will not use any other program. And we are not ready to use any web portal to copy-paste data and to share them a difficult way. And we say, we have developed a tool how the electronic health record can be a part of your health information system. As from Denmark presented, you will see all the data about the patient downloaded and online shared with the electronic health record system. This is what we feel is crucial, and we do not force any physician to change his program, his supplier, or any health information system. We would like to use this electronic health record to support diagnosis, treatment, and prevention. Prevention is a good part because this is the field where we can bring in the patient-centered system more information to patients and provide them with more data and somehow increase their education in health. That's why we came with the project, I would say platform. It's www.zdravel.cz. Don't try to pronounce it. It's a Czech, I would say, e-health world. And we brought a platform which contains just basic data of the patients, anamnesis, medication, emergency data set, medical records, treatment, and family profiles. For example, on the next page, I will show you the accesses to the system, and we see that, for example, family profiles are very well used. Main parameters are that it must be easy to use, open and independent platform, and we would like to be partners of the EU government, so we will never get into any exclusive cooperation with anyone. We will keep it open and independent. Czech Republic has a certain, let's say, specialty. We use DASTA standards. Therefore, we developed translation between HL7 and DASTA, which is mostly used in Czech hospitals and Czech medicine. It's a platform, I would say. It's not an application, so we would like to keep it open for telemedicine, research, fitness, and other third-party solutions. Right now we have received an expert opinion which is stamped to be, let's say, compatible with GDPR, and we would like to be a partner of the e-government to be in line with also national e-health strategy which was adopted in 2016. These are our milestones. After, I would say, 2 years of enormous amount of development work, we launched in September 2016, and since that we have 16,000 plus active users, and we have 300,000 logins. We have partners from private sectors. The main partners are Lékaře and Záchranka. I will explain you what's that. Záchranka is a very interesting application which shows GPS data to emergency service and is used by, I think, 500,000 Czech users for emergency calls. And we connected with this application in order not to provide emergency service only with GPS information, but also with emergency data set. We also cooperate with web portal lékaře.cz, which is, I would say, one of the biggest portals with accesses mostly over 1 million per month. And there users can ask general questions or special questions to physicians, and we have connected our electronic health record system to this web portal in order the physician has more information about the person who asks the question. We have supporters from let's say, professionalists. I will not name them, you usually know them all. So we cooperate on Zdravil with these private companies and with these experts to bring it more to people and to get to this point to patient-centered system. We don't have our own picture because we've taken pictures from, I would say, the eHealth world, and we say that if anyone brings us 5 differences, he's the winner for us, because we feel that this is the strategy of patient-centered system of electronic health record where it goes. So this is our activity. We would like to be, as I said, a partner for government and to sit on the side of private partnership of the e-government's main aims in e-health. Thank you very much.
Thank you very much. I have to thank all of the presenters for excellent presentation. Now we have time enough for the discussion, so it's open. Is there any question from the auditorium at the moment, please?
It's Roman Krekiš, and I'm from outpatient department of cardiology, Kardiologická from Prague. I have a question from a Hungarian lecturer, and I have one note. In Czech Republic, eHealth is not working. There is a problem to exchange some data from another department. It is not working. And Czech doctors and nurses are always complaining about working conditions. They are leaving to work abroad for better conditions, doctors and nurses. And from your presentation, I see that in Hungary, eHealth is well developed. I appreciate it, and this is working. So I have a question if it is some help to help the working condition for Hungarian doctors. What's the situation with nurses, and if there is problem with overtime work and so on?
Sometimes I run into issues. There are huge issues in Hungary in quality, accessibility, and fortunately the migration of health workforce is decreasing rapidly because there were salary days and all that stuff, so it is improving. They are also complaining about the administrative burden on them. And many times they are not necessarily fitting the DRG records well because they learn 8 codes and they use the 8 codes for the similar cases, so it is not as disciplined and trusted data as it could be and as it can be in Denmark, for example. So there's an issue about administrative burden, and there's an issue about the diffusion of innovation, because some GPs are already using the data access, the integrated data, for following the patient pathway of their patients. But it is not necessarily well organized. The diffusion is not there yet. It's since November the 1st that this system is up and running. But they accepted it, and that's why I showed you that many data mining charts, because previously we had a lot of cases when doctors could use the data for the benefit of their patients or for their own benefits. And in Hungary, somehow, yes, complaining the administrative burden, yes, but they saw the power of data and they saw the opportunities in that. So and one thing, in Hungary there is no private health insurance. So if there is a cut in budget and there is a budget pressure on the doctors, then they do not feel that it is for the benefit of somebody making profit out of milking them through administration. And many times when there is a private insurance system and there is a plus administrative burden, then pay me for it. Pay me for providing you the proper data. So there is this division in that sense.
Thank you very much. Next questions. I ask all of you, where have you observed the major barriers in the development of eHealth in your countries? I will start in Denmark. So major barriers in the development of eHealth.
Well, definitely one barrier is to get the stakeholders engaged and get them managed. We were fortunate that when Medcom, the health data network, was established, the Ministry of Health did one clever thing, because on the board of directors of Medcom, they placed all the stakeholders that was necessary for the mission. And that created a mechanism by which everybody thought you might as well go along. A hospital CEO who, for instance, wouldn't invest in modifying his lab system, he thought twice because he knew somebody from his organization would be on the board, so somebody would probably later hit him with a hammer, and that made the process flow. And the same way of organizing the stakeholders was used for the national eHealth portal and for other initiatives.
Thank you. May I ask, how is the situation in Hungary? Where have you seen the major barriers?
The major barriers is the strategic leadership, the methodology supporting the developments, and the industrial lobby.
Yeah, very important. Good, thank you. May I ask you? Yeah. Okay.
Well, from my point of view, one of the main obstacles, barrier, is that eHealth in general has bad reputation, because there were like several projects which failed, and now all the doctors and maybe also the public in general have this point of view that eHealth is just about a lot of money and no benefit. So that's what we need to change. We need to change the mindset of the healthcare professionals, and also and to bring that benefits, to show that it can really help either the doctors or the patients, and that's our aim and our task. Yeah.
Thank you very much. And Mr. Petřík?
I agree with all speakers generally. What I would add is that we also need some let's say base for the eHealth, which is mainly the standardization, registers, legislation, as well as funding, of course. So these are, I would say, tasks for the government mainly, because there must be some rules and some standards which has to be fulfilled, generally speaking. But I would say also the industrial lobby is huge here. Our experience is very often the same. We agree with the director of a big hospital, we agree with the head of doctors, the team of the doctors, we agree about some advantages and added value which will be provided to the patients, so they understand the help of eHealth. But then we go to IT firm which provides the health information system, and the reply is, why should we do it? You know, why? Will you pay us? And we say, no, we don't have funding for this because we are private initiative. So this is very often the problem.
Thank you. Your remark?
Yeah. In Hungary we did a dirty trick. We told them that we develop a national cloud, so if you do not comply and do not make your system compatible, then we will replace it with a national cloud-based system. And then in 3 months they solved the so far unsolvable data integration issue.
Perfect. Your question?
Klesla Vysoká škola ekonomická. Já bych se dovolil upozornit ještě na jednu bariéru, zejména jak si, možná, že jsem to špatně pochopil, ale kterou bych nazval vnitřní bariérou nebo omezením v tom našem projektu českém eHealth, a o to bych chtěl víc ocenit přístup, který jsem viděl u dánského příspěvku a v dánském přístupu. Mám takový pocit, že tady chybí zcela péče o elektronizaci nebo digitalizaci podpory zdraví. Česká republika přijala, my jsme se toho nějak účastnili před 3 lety, velký program, který se jmenuje Zdraví 2020. Já vůbec nevím a nikdy jsem nenarazil na to, že by eHealth se zabýval fakticky takovou věcí, jako je v podstatě primární prevence nebo podpora zdravého způsobu života. Já tady mám náramek a dneska vidím, že jsem ušel 4865 kroků. To je málo, to je polovička, už to asi nedoženu. Ušel jsem 2,8 km a spálil jsem si 32 kalorií, což je velmi málo. A myslím si, že eHealth, česká eHealth, by měla propojit cestou big data, v podstatě tím maďarským způsobem, když můžeme čerpat zahraniční zkušenosti. A v podstatě tato data, to je wearable device, které nám umožňují úžasné věci, to znamená nejenom sledovat, řekněme, zdravotní stav nemocného člověka, a člověka zdravého, jakkoliv já mám náběh na obezitu, takže dominálně směřuju k diabetu 2. stupně. Čili v té oblasti péče o zdraví a řekněme těch primární prevence těch occupational prostě, nemocí, těch civilizačních, si myslím, že tady je poměrně dost velká vnitřní bariéra myšlenková, nebo jako slabé místo, které v podstatě tu efektivitu celého programu snižuje. My jsme totiž udělali několik studií na Vysoké škole ekonomické a můžeme dokázat, že naprosto nejefektivnější a nejlevnější forma udržení vysoké úrovně veřejného zdraví je zachovat to zdraví a ne ho obnovovat léčbou.
Thank you very much. I have to add that the primary prevention programs will be certainly a part of the CHIP eHealth because it's very important, and there will be some project I do personally, or my team with Professor Adamkova. We are comparing the healthcare in 2 regions, in Zlín and in Olomouc, comparing to Prague and other development parts of Czech Republic. And what we see in the pilots that there are huge differences in the healthcare. So the aim of these primary prevention programs is to develop a standard, a registry of primary prevention of oncology, cardiology, and other levels. So thank you for your data. And next question: role of registries in the healthcare, because I know Denmark is leading country in the field of medical registries. You in Denmark, you have a long-term overview about the development in the field of cardiovascular diseases, oncology, stroke, and others. So, how is it organized in Denmark?
Well, this kind of data is coming from the clinical databases. We have around 70 of those. So every clinical specialties, they have been collecting data on a specific detailed level in order to make it available for research and improving the treatment and also prevention initiatives in those areas. And if you put that together with the data in the National Service Platform, the data in the biobank, you also get a very powerful tool for doing big data. From Hungary, we saw some examples where you can see the prevalence of smoking compared to lung cancer, I think it was. In Denmark, we can use the data for the same purpose, for instance, to see the prevalence of diabetes 2 or heart attacks in the municipalities, and that way have a dialogue with the municipality going along saying, big data show that you have more diabetes 2 patients or heart patients than the neighboring municipality. The environment is not that different, you have the same industry. How come? Is that because you're not good enough at your prevention initiatives, for instance? So yes, the importance of big data is there, and we see in Denmark that having this architecture, this focus on data from a lot of sources tied together with a unique patient identifier is what makes this possible.
Thank you very much. And the situation in Hungary we probably have seen. How is the situation with the medical registries? You showed mostly analytic data, and I'd like to know how are the medical registries?
In the system, there's a registry engine developed, but that's a so far non-functioning component of the eHealth dataset or eHealth system. But we also have some national registries, National Cancer Registry. Then there is a pediatric intensive care unit registry or pediatric cancer registry, and the integration of these registries is underway. And also there is a National Innovation Fund funded cohorts of projects, I think at least 9. One of them is doing the telemedicine ecosystem, including the incentive system for physicians to collaborate, and also the joint national diagnostics databases with artificial intelligence function. And there we see, for example, all pathology data is in SNOMED format in the Hungarian pathology departments. And there are 2 pilots, data lake pilots. One data lake pilot is at the Pécs University, one is at the SMLS. And we made the neurologists, the urologists, the pathologists, the lab physician, and their data experts sit down, go through the database, what are the shortages, when did they not put in the right data, how can we substitute that data with automated data import. So now we are working on the methodologies to not even to put the registries right, but to make the registries data lake compatible. So, but that's in the research stage.
Thank you very much. Next question from the auditorium.
First, I'm really happy to see the highest representative of health problematics to talk about eHealth and electronization. And I would like to offer you the cooperation, because I'm from the Ministry of the Interior from the Czech Republic, and we can offer you the help and everything if you need something. You talk about base registries and everything, we are the representative of this problematic. So thank you very much for this. And now to question to representative of Denmark and Hungary. Do you have the experience with the cross-border exchange of medical information? Because there is a big project in Europe called under CEF Telecom, and we are part of it. Maybe your countries are too. And I would like to see if you have some experience and you already interchange some medical information with other countries. Thank you.
you mentioned, I guess there may be research organizations or other organizations in Denmark who are involved, but we were involved in the EPSOS project, which was also on my chart and which also was fed by data from the National Service Platform. The EPSOS project was about sharing prescriptions. So I know that is kind of now expanding into to really sharing electronic prescriptions between those countries who are involved.
Yeah, the Minister of Internal Affairs was very important in Hungary because the Minister himself is responsible for electronic public administration, so he was very committed to this purpose. Then the Connected Europe facility, yes, we are involved. I think bureaucracy is very slow. Funny enough, but in the joint action, the JSM supporting the eHealth network, it is our university is also a member. So my understanding is Europe is very slow in doing that. So from the money we spent for coordination, we could have developed an open source solution for that. That's my understanding.
Thank you. I would like to ask Mr. Adam what he will do for the registries in Czech Republic, because we have luck in this field.
Sure. I've already mentioned in my presentation the National Register of Healthcare Professionals, which will start working in March. Sorry, and there are already very good registers in terms of oncology. I think it's one of the best examples. It really works, and there are great data. But in general, we are working on it. Like there is this Institute for Statistics in healthcare under the Ministry of Health. So there's still quite a long way, but it's being developed, and I hope that it will be used by maybe in the future also not only the Ministry of Health, but that we will have this open data format. That's what.
So for payers.
Yes. I think it's very important, and I think that we should validate the data. But why not to present them, why not to open them for some non-government organizations and big data people who like to work with the data mining and so on. So that's what is also my aim, so we'll see.
I strongly believe that you have to define the, let's say, basic network of the registries that are necessary. So starting from the oncology over cardiology, over neurology, pediatrics, and things like that. So I think 5 or 6 registries.
Diabetology and so on. Yeah.
Good. Next.
I'm not from the government. However, I think it's worth commenting on one really big change, which I think is going to happen in this summer here in the Czech Republic, and it's the e-identity. I think the Minister of Interior Affairs could comment on it, because as you said, you have the e-identity card. We will launch the new law on e-identity, and the new owners of the e-identity card can identify themselves via internet and use the certificates to, let's say, manage general legal acts, I would say, as well as maybe in the future they will be able to access some eHealth platforms and electronic health record databases. So I think we are on a good way. However, it will take some time, because each individual in the Czech Republic must receive a new ID card. I think in this very moment it's a voluntary change. However, I think each year there is something like 1.5 million ID cards changed, so it will take approximately 6 or 7 years until all of us will have new ID cards, and we could be e-identified electronically by the system.
Next question from the auditorium, please.
Good afternoon. My name is Lenka Kovačeva from Moderátor Fund. I was going to have a question for Mr. Vojtěch regarding open data, but he already mentioned it. However, I have a question if there's going to be some pressure from Ministry of Health regarding the Institute for Drug Control and the UZIS, which is Institute for Health Information and Statistics in Czech Republic, because they are not really able to share the information and share the data with the public. There's quite pressure regarding the NGOs and public, if we are going to talk about this institution. So it's not just about the data from Ministry of Health, but even the data that are from the institutes that are part of eHealth and digitalization of healthcare in Czech Republic. Thank you.
Yeah, I already said that I am in favor of this open data mindset, but to be honest, it's not so easy because people at the ministry have sometimes different point of view. They think that the data should be protected, which is true. But on the other hand, I don't see anything bad about publishing data which are not personal, of course. It would be against the law, but which are only statistical, and people can work with them, some NGOs and so on. So we are now discussing it with Mr. Dušek and his colleagues, so I hope that it will work and that you will be satisfied soon.
Thank you. Very open question. Payment for eHealth services in your countries, and what you will do for it? Are the doctors paid extra for the eHealth services or institutions or not?
Yeah, the funding model in Denmark is that typically the government will set a sum, start up some aside for some of the initiatives which will go to hospitals and municipalities and others involved. And then of course the general practitioners, remember as I said, they were private enterprises in Denmark. If we want general practitioners to do something in Denmark, we need to establish a service fee for payment. For instance, when we went to having opened up for the ability to have e-consultation and e-prescription, they have to have a special fee for handling that. So that's a mechanism we use in Denmark.
Thank you. And in Hungary?
So the entire eHealth system is financed by the government. The development was financed by the EU structural funds, or the biggest part. There is only one typical telemedicine service or eHealth service that is financed, and that is the transtelephonical electrocardiogram service on the ambulance cars. On each and every Hungarian ambulance car is a transtelephonic electrocardiogram machine. But the model that they are developing now is like the primary care indicator financing. For example, if a certain proportion of the patients in the district go for screening, then the doctor receives a certain sum. So this kind of eHealth service funding schemes are emerging, and in 1 or 2 years there will be a broader scheme available. They are working on it actively.
Thank you. What you will do as a Minister of Health to support the eHealth payment in cooperation, for example, with payers, with insurance companies?
Yeah, of course, the main projects are being financed from the state budget or by EU funds, and the payers, the health insurance funds, right now, for example, give some bonification to the doctors who prescribe electronically, which is kind of financial initiative. So I think we should maybe in the future continue with this, because the world is about money, and there must be some motivation in terms of bonification, like that we financially support doctors who implement some eHealth products, and so I think it's natural, and it will be like that, not only with the electronic prescription, but also in the future with data sharing.
Thank you very much. Another important question, legal aspects. Do you have in your countries extra special eHealth law?
Yes, right. As I speak, there's a process on opening up the data, actually given the Ministry of Health more control on how we share data. Going back to when we started to share data through the National eHealth portal, they had to change the legislation to make that possible, and they did that. So there is this linkage, and also in relation to personalized medicine, we will see more initiatives. So there's very much focus and conscious around the fact that the legislation has to be updated to make the progress of eHealth, telehealth, personalized medicine possible.
Thank you. And in Hungary?
There is a special eHealth law that is basically describes who can access data under what condition and who is responsible for what and who is responsible for the management of the system. One thing is lacking so far, and that's the regulation of secondary utilization of health data. That's not in the legislation yet, but it falls under the research ethics legislation. It is done, it can be solved, but there is no special regulation. We will need it in the close future.
Thank you. And the Czech Ministry of Health?
Yeah, I mean, you know as well that we started to work on the eHealth law, new eHealth law, which will establish some basic standards. So that's we have now the working group which started to work on this new law. So and it will be done hopefully this year and in force in the next 1 or 2 years. So, and that will be the basic standards to simplify the data sharing and so on.
Thank you. No other questions from the auditorium? Probably the last one from my side is the role of private sphere in the development of healthcare. So we have seen a good example in Denmark. So let's say in percentage of payment or development and participation, so is half and half, or how is the situation?
The electronic health records for the regions, they are developed by local companies, and I say local because if you study electronic health records in the Nordic countries, you will find that there's not many worldwide players, because we have a culture going back to when we started to work with electronic health records, that we develop those systems for the clinicians. In many countries you have a tendency to kind of expand the administrative system, the patient administrative system, to support clinicians, and that is wrong. So there's a different culture in Denmark. When it comes to the national service platform, it's actually like you're planning to do in Czech Republic. It's architected by the public authorities, our national board of eHealth, and they design and they govern the design, and they decide what has to be done, and then they engage private developers to develop the stuff that is all under control of the public system.
Erik?
You know, many times the implementation of these systems is outsourced to private companies, and my understanding is that there has to be an agreement between government and companies that there should be the backbone should be a public system, but that should be open to various applications, and we have a world market. Europe is a leader in universal health coverage, solidarity and risk-sharing systems. If we can develop eHealth solutions for ourselves, we can export those eHealth solutions. So develop a public backbone and open it for intelligence applications that are supporting the clinicians, that are supporting the patients.
Thank you. No more questions from the audience? If not, I have to thanks all the presenters. It was a great discussion, great presentation. So thank you very much for being here with us, and I hope it is a good hope for the future. So it's on your side, and we all are here will help you with this. And hopefully in 1 year we'll be here together, we can show some results, let's say the phase 1. Thank you very much and have a nice day.